Yes, so I think now is the time to begin. Well, good night, everyone, and welcome to this third science discussion organized by the science chapter at at our university, Universidad Nacional Mayor de San Marcos from Lima, Peru. And we are really excited to have in today's discussion the company of Valeria Roldán, which is a very special friend and also a member from Neurology VMR, Virtual Morning Report from CP Solvers, which is the academic project that inspired this format of science discussion. So I just want everyone to give a warm welcome to Valeria Roldán. And yeah, I think I can pass the mic to you to say hi and present yourself. Please, Valeria.
Hi, everyone. I'm very thankful that you invited me today. Thank you, Gerardo. As he mentioned, we are really good friends, so I'm really happy to be here. And yeah, really ready to discuss some neurology.
Wonderful. Thank you so much, Valeria, for being here. And yeah, before we start, I think um, the other people involved in this discussion and making it possible today can open your mic and present yourself, maybe just a brief statement. And why don't we start with the case presenter, Sandra Uriol? Can you open your mic?
Yes, well, good night, everyone. My name is Sandra Uriol. I am a six-year medical student this year, and this is my first time presenting a case in a science discussion. And I hope you can enjoy the case, hope you can enjoy the discussion. I'm very glad that Valeria is here. I think it will be a very productive discussion. So maybe just to mention, I did my best to recollect this information. So I hope you like it.
Thank you. Thank you so much, Sandra. I think I didn't present myself, so I'm going to present myself now. Uh, My name is Gerardo Luna Peralta. I'm also a sixth year medical student, and yeah, that's basically it with me. And I'm very grateful to be here along with a lot of wonderful med students from my university and also with Valeria Roldán. And yeah, okay. And I will pass the mic now to Arturo to introduce himself.
Hi everyone, my name is Arturo Ruiz. I am a fifth year medical student, also in the University of San Marcos. And yeah, I'm really excited also to discuss one more case in our science discussions, and a little bit nervous also today, but I think we can make a great discussion today.
Yes, let's have fun discussing. And yeah, who's going to do the teaching points? I think it is Guillermo, or am I mistaken?
Yes, so maybe I should present myself too.
Yeah.
I'm Guillermo Mantilla. I'm a second year medical student, and I'm also from the University of San Marcos.
Nice. Thank you so much, Guillermo, for doing the teaching points. Guillermo has just finished his first year, and he is already doing teaching points here. So I really, I'm amazed by all his initiatives and just his involvement so far in our projects. So yeah, I think we can begin now. And we've already known that the chief complaint is syncope, but I don't know if it is the full chief complaint or if you've added more information in the chief complaint, Sandra. So maybe you can share that with us so we can start the discussion.
Yes, well, there is more information, but not so much. The chief complaint is syncope that happened yesterday in a 62 years old woman.
Okay, so now it gets more interesting, but I don't know if my co-discussants here, does any of you have any reflex thoughts or anything that you want to add, or do you want me to go first? Please don't leave me alone.
I think I can go first. as the oldest one here, I think I'm very impressed that everyone is so young and so committed to neurology already. Um, so I think when I think about syncope, I for sure, as a person that loves neurology, often think about the mimickers of syncope first, thinking, okay, is this going to be maybe something that is not a syncope, like a seizure or any other cause of loss of consciousness? And for loss of consciousness, we often, in CP solvers, we have like a mnemonic of the four S's, syncope, seizure, sugar, and then the substances, I believe, is the fourth one. Um, and with substances, of course, like opioids is a very common one in the US, but otherwise we think about, mimickers like seizures, or, often when someone loses consciousness in the emergency room, we do like sugar first because it's a very easy and very easy to manage type of cause of loss of consciousness. And then to differentiate between syncope and the other S is a stroke, I should say. And then to differentiate syncope from something like a seizure, we have to think about, like, okay, does this patient had any abnormal movements? Did they bite their tongue? Did they, had any release of sphincters? Like, did they pee themselves? Because these are things that are most common with seizures. And if not, then, we think, okay, this is a true syncope. But that's kind of my first branch point. But we'd love to hear from all of you as well.
Wonderful, wonderful, Valeria. Thank you so much. Yes, I think you asked a very important thing, which was that, which was to really know that syncope is a diagnosis in itself. So if we hear that we have a patient that has syncope, then we should really pay attention to this history, because the history has to really fit with the common history of a patient that has syncope. Otherwise, we should doubt the diagnosis, because the diagnosis has to be made by ourselves. So I know that when we hear syncope, the first thought that we have to have in our minds is maybe this was a transient loss of consciousness, and that transient loss of consciousness could have been interpreted as syncope, or maybe it was a fall and it was interpreted as syncope, which was which is just one of the causes of transient loss of consciousness, as you very well reminded us with the four S's. So I think it's very important to know that. And the next thing I would like to know, for example, in this patient, is who witnessed this episode and who witnessed it, because obviously if you have a diagnosis, someone made that judgment. So if physician made that judgment, so we gotta get to know the arguments behind that. But if just a person, or even if just one person witnessed it, we need to know the specifics of it, because the circumstances in which the patient lost the consciousness is going to give us a lot of information. So yes, those two things I think are my main comments with this. I don't really take that much from the age of the patient. I know that causes like, for example, a stroke take more importance as age grows, because, for example, for a seizure to present de novo at this age and causing transient loss of consciousness, or that would be unlikely, I think. And the fact that this is a woman also doesn't really give me that much of information. I would say that for this to be just a case of syncope, and that in this context that we are discussing a case, I think that it has to be it is not the most common scenario that one can find themselves in, which a patient has recurrent episodes of syncope that you doubt the diagnosis, and then neurology comes into consultation. But I think this is just an introduction of the whole picture of the case. So I will I will keep my thoughts brief, even though I just spent 5 minutes talking talking about my thoughts. But I want to know, what are your thoughts, Arturo, on this?
Yeah, well, as you two talk about, the first thing will be to determine if this patient is really having a syncope, and that all comes from the history. And having know that a patient has a family that has witnessed her episode of syncope will also really help. I think from the age of the patients, maybe we can start thinking, or maybe in the possibility of differential diagnosis, the probability that this patient may have a structural cardiac problem, because one of the diagnoses that comes to my mind when I hear a patient with syncope is some way of cardiac dysfunction. That also really goes with the pathophysiology of syncope, knowing that syncope is mainly due to the diminishing flow in the brain of a patient. And that can be either to diminished blood pressure or to an increased brain blood flow resistance. So in a patient with that age, maybe cardiac causes as a chronic factor, maybe something that we should explore in this patient. But that all will only be valid if we establish the diagnosis of syncope in this patient. So hearing all the history will be really important, I think, in the next step. So I think we can continue.
Wonderful. Wonderful. Thank you so much, Arturo. And yes, we have to remind ourselves that this is a real patient, but this is not the context of it. This being a neurological discussion, it's not relevant in analyzing it. We have to keep in mind that actually, I think the cardiac causes are the most common, and when you approach a patient in any setting, you should remember the cardiac causes versus the non-cardiac causes, and that approach is also relevant. Yeah, so I think we can hear more information from Sandra.
Yes, so maybe for one of the main questions that you have, there were any big witness, because the patient lives alone, but I will give you more information. Well, the patient reports that she fell and then she woke up on the floor with urinary incontinence, when an urinary incontinence episode yesterday at night. There is no tongue biting, no bowel incontinence, and she do not remember how the events prior the fall. And she also is unsure of how long she was in the ground. She believes that she lost the conscious. She's kind of worried because she thinks she had a stroke, but she's not sure of what happened before this episode, like if she has any headache, dizziness, but she do denies chest pain, shortness of breath, nausea, vomiting, abdominal pain, and urinary symptoms. But she comes to the ED with her father, and he also says that the patient has 1 week of difficulty with the speaking and forming thoughts, like she speaks in fragmented sentences, and she also has memory issues during this past week.
Sandra, if I may ask you a question, does she know exactly, or like, can she estimate about like maybe if she was on the floor for like minutes, an hour, or when you mentioned like she woke up on the floor, like is there any like time frame for that, or does she not know? It's okay if she doesn't know.
I think she doesn't know because it's not like exact information. So she probably doesn't know because she also lives alone. So there is no more information.
No, perfect. Thank you for your throughout HPI. Gerardo, I don't know if you are gonna say something or if I can just jump in with my thoughts.
No, please continue. If you have some reflexive thoughts, you can continue. If not, I can continue. I am
For sure.
I'm intrigued by this case, but go ahead.
Yeah, I just wanted to say that I loved your thoughts and Arturo's as well. When Arturo mentioned about syncope in itself, that it's exactly what he mentioned, just that blood is not getting to the brain, and for that to be the case, we need to think about the heart, which pumps blood to the whole body, and also the vessels that transport the um, the blood to the organs, and for elderly patients often, the vessels, I mean, I love that Arturo's point about, cardiac diseases being very, very prevalent in older patients as well, but I think the vessels are often, my reflex thought in this age group, just because orthostatic hypotension is something that is very common when you get older. Your parasympathetic tone kind of, takes it becomes very much more like a prominent. So it is not rare to see elderly patients that have orthostatic hypotension, or even they have hypotension just because they dehydrated, because they cannot access water as fast or as easy as they did before. But for this patient, I think I'm very worried about something structural going on in their brain, just because of the facts that you outlined, Sandra, so well in the last part of the HPI. The fact that she has also a week of difficulty speaking, forming thoughts, forming sentences, apparently talking. And, I think it's very fair to address her worry of a stroke in this case. Stroke is a syncope mimicker. I think at this point I will need some more information to kind of, think, okay, what is this patient going through? Because if she has had a week of difficulty speaking, is that the main reason, or like the chief concern, or is it this new episode? You know what I mean? So yeah, I think what I'm trying to say is, okay, is this patient having a syncope separated from what apparently is a stroke-like picture with the apparent aphasia she's having? Or is this part of kind of conjunction of symptoms, like aphasia a week before, and now having a syncope episode that can be maybe a recurrence of a stroke? And for that, I would like to know if she has any beyond the aphasia, any other localizing symptoms, such as weakness, weakness in the extremities or in the face, or doing like maybe a mock exam to kind of outline the profound, if she has any profound deficit in the cognitive aspect of herself. But I'm rambling totally, so I'll pass them back to you both. Sorry.
No, don't worry. Those thoughts were amazing. And yeah, do you, Arturo, want to tackle this next part, and then I'll finish?
Yeah, thank you. So once I heard the part of urinary incontinence, I remember one of the pathophysiologies of syncope, which is vasovagal mediated, and the parasympathetic increase in the system can cause urinary incontinence. But then reading more about the history of the patient, the fact that she wasn't sure how long was on the ground and that she doesn't remember the events prior to the fall makes me really doubt about syncope. Mainly because syncope is a very brief event in which the patient falls to the ground, and in a very few seconds or minutes, the patient returns to consciousness, because when the patient falls, the blood flow in the brain reestablishes. So in this case, the patient that doesn't remember in which time of the day she fell and why did she fell is very intriguing and makes me wonder about other causes that can present this way. I also started thinking about maybe if this patient with some cognitive issues has also had some problem in the coordination of her limbs, of her role with limbs, because if she had some trouble with coordinates, then maybe that is the cause of the fall, and maybe that is the cause of the syncope. Also, if the patient doesn't remember why did she fall, maybe when she falls, she get a trauma on her head, and that we'll only know by seeing the patient and with the exam. Seeing any signs of ecchymosis can of any sign of damage in the head can maybe tell us really a lot about that. I am also really relieved that the patient doesn't have chest pain, because, well, we talked about before that one of the causes of syncope can be cardiac issues, And chest pain is a symptom of a spectrum of those cardiac issues. Anyways, we will really look into the exam for establishing very well the state of the heart of this patient. So with all this HPI, now I'm really worried about why this patient is having a week of cognitive problems. Maybe, as Valeria said, a stroke can explain focal issues in this patient, can explain what the patient felt. But the fact that it's a week, it really is really intriguing. Maybe another issue is going on in this patient, and I think we can really go more with the PM past medical history of this patient to really um, um, put away any cardiac issues and focusing more on the neurological examination. So those are my thoughts right now.
Thank you so much, Arturo. I think you all and your brilliant thoughts mentioned everything that should be mentioned, but I think what I can add is that this is a very personal case, because when you have an HPI that starts with a fall, and then you have some phenomenon after that, you can't say that you can say that one hypothesis is that the fall caused a concussion, and the concussion can explain the phenomenon that we are witnessing, but it can be also completely unrelated because of the time course of the cognitive issues that this patient has. So I think at this point we can't really say a lot of things. We know that this patient had a fall, had a transient loss of consciousness. She woke up. She doesn't refer any postictal state of confusion or something, and she apparently didn't have no, not apparently, sorry, she had release of sphincters but no bowel incontinence. She didn't have a tongue biting, which is also relevant. But she also the father is also referring some difficulty with speaking, and here it's also difficult to interpret that, because what is difficult to speak in for someone that is not a physician? It's difficult to say, is it dysarthria? Is it aphasia? Is it just a problem with the volume of the voice or something? It is not. I'm having trouble trying to explain or trying to identify what was the family, the parent referring to. But if I had to guess, or if I had to point a hypothesis on this, it will be that this may be a consequence of the fall and the blow on the head, and that can explain, I think that could be a possible explanation of an insult to the cortex, and that causing cognitive deficits, I think. But I think we will learn more about the case and as more information is unfold. So please, Sandra, tell us more.
Okay, well, great discussion, guys. Well, I will give you the past medical history information. This patient has gout, hypertension, and atrial fibrillation, and the medication that she uses atenolol, chlorothalidol, allopurinol, and aspirin. About the family history, there is nothing relevant in the family history. About the social history, she works as a saleswoman, and she lives alone, and she denies any substance consumption like tobacco, alcohol, or any drug. And there is no allergies. I don't know if you want me to tell more about maybe the physical exam, or do you want to talk about this?
Yeah, please. I think you can reveal more from the vitals and exam.
Okay, so about the part of the physical exam about the vitals in the emergency department, she presents with normal temperature. The heart rate is 59. Blood pressure is also normal. The respiratory rate 18. The saturation is 96. In the exam, she's well appearing, no apparent distress. About the head, air nose central. She presents with right side facial drop and left tongue deviation. And the result of the exam, I think it's normal. Cardiovascular, pulmonary, and abdominal, there is no abnormal findings. And also with the extremity and skins, that part is fine. So I think that's the information I can give at this point.
Thank you so much. And I think it's my time to to begin with this next set of information. And yes, so I just want to talk about my reflex thoughts when I heard the the exam, the general examination. Well, obviously we apparently have uh, a focal neurological deficit of right-sided facial droop. So if we have right-sided facial droop, that um, we can interpret that the whole hemiface is involved, and for that to be the cause, it has to be a peripheral cause rather than a central cause. Um, but it can also be a central process causing the upper part of the face to be spared. But I don't really if I hear right-sided facial droop, I am inferring that this is involving the whole right side of the face, and for it to be a central cause of, I mean, in the central nervous system, it has to be an affectation of the facial nerve. So I'm really, my reflex went to the brainstem, but let's also see the other part, which is that the left tongue, there's left tongue deviation. So the tongue is pointing towards the left. So if the tongue is pointing towards the left, this means that when you protrude the tongue, the genioglossus, which is the muscle that is in charge of protruding the tongue, is not working well, and that is in charge of the hypoglossal nerve. And when you have a peripheral nerve problem or an insult to the hypoglossal nuclei, then you have a deviation that is ipsilateral to the insult. But if you have a cortical issue, you have the opposite. And so as I was trying to localize this lesion, if this was a right-sided facial droop due to an insult to the nuclei of the facial nerve, that should mean the right lateral. So yes, the right lateral pons, and for the tongue to be deviated, it has to be the medial tongue. The medial medulla oblongata. So really, the localization isn't really doing making a lot of sense for this to be focal neurological deficits. So that's why now, out of my reflex thoughts, I think I can say that maybe this is not a process that can be understood based on the anatomics of the brainstem, but we should not anchor on that localization. Apart from that, there are really no other positive signs, and yeah, the fact that she's a saleswoman and she lives alone. Well, if she lives alone, obviously that complicates things because there is no witness, so we won't know what happened. Um, but there is also some cardiovascular problems that really worries, makes us worry, like hypertension and atrial fibrillation. For atrial fibrillation to cause syncope, I think it's unlikely. I think it's more likely to have embolic events secondary to atrial fibrillation. I haven't heard of it causing syncope. I think it's more common with aortic stenosis and hypertrophic obstructive cardiomyopathy. But yeah, I'm really curious to know what are your thoughts on this. And yeah, I think any of you can open your mic and share your thoughts if you'd like.
Yeah, then I continue. I think what are you saying is really interesting for this patient, and I am really also having troubles trying to find a focal process in this patient. The atrial fibrillation, as you stated before, is mainly related with a stroke in a patient, but if we try to focalize only on the pathophysiology, the atrial fibrillation isn't, the atrial component of the heart isn't putting all the blood into the ventricles, then the ventricles isn't putting all the blood into the system. So atrial fibrillation, pathophysiologically speaking, can cause syncope, but I don't think this is really the case because we are really having a lot of symptoms in this patient. I was really intrigued at the METs because there are METs that can be related with syncope, and also something that I haven't mentioned before, but now thinking about diffuse process in the brain with syncope, something that can come to my mind is a vascular process inside the brain, because there are a lot of vascular causes. For example, a vasculitis, a CNS vasculitis, that can present with multiple strokes in the brain, and that may be related to the difficulty speaking, to the right facial group, if it is really a central facial group and not a peripheral facial group. And also, a vasculitis can increase the resistance of the blood flow in the brain, and that can cause syncope. And anyways, even if it is in syncope, in a vasculitis of the CNS can present with loss of consciousness. So that is really one of the things that comes to my mind, thinking about a diffuse process in the brain that can present with all these symptoms, with cognitive symptoms, with a right central facial group, and with a transient loss of consciousness. So that is all I have to comment for now. Go ahead, Valeria.
I love your discussion. I think you're doing amazing. And I just want to say that I'm loving this case because I feel like it's a really great exercise on the importance of framing a case, or because, patients often come to the ED and they say, I've syncopized, or like, as we will say in Spanish, like, me he desmayado. And we would often think, okay, like, this is, okay, what are the most causes of, syncope? But often the use of that language can compromise our framing of a case. I think it is a great example because how would I frame this case at this point? It would be like a 60-year-old woman with cardiovascular risk factors, including AFib, that presents with a transient loss of consciousness. I would not call it syncope, I think, because transient loss of consciousness kind of gives us a broader DDX, and I think at this point it's really helpful. And also, okay, so transient loss of consciousness with release of sphincters, with our, past episode a week ago of speech disturbances or problems, and, an exam that is remarkable thus far with normal vitals, no hypertension, which is reassuring, right facial droop, and left tongue deviation. And just to comment a little bit on what you said, I think first, what Gerardo mentioned about these language problems, I think before I heard the exam portion, I was thinking, okay, maybe it's aphasia, because from my experience and my knowledge, and correct me if I'm wrong, when I hear often, in a question stem, for example, in an exam, when they mention like speaking in fragmented sentences, I think, okay, this is very typical of like Broca's aphasia. That's because, when we talk about speech, we talk about content, we talk about fluidity. And when it comes to fluidity, you can have problems such as, aphasia, like Broca, like you have, like, I don't know how to say it, it will be like high, like
Expressive.
you, yeah, exactly, expressive aphasia, but I'm trying to like do an imitation without sounding stupid. Um, but basically, it's like fragments, the person, you understand at the end what they're trying to say, but they're just very slow, and they having like a problem, with the fluidity, rather than with the content. Um, and I think when you talk about dysarthria, I often think about problems that when you really cannot understand very well what they're trying to say, they can be speaking very like fluid in the sense that it's fast, but it's not very coherent. And I think it's a point to the exam, because with the right facial droop, which we don't know if it's central or peripheral, it can be a cause of dysarthria, and the left tone deviation as well. And I think, Gerardo, what you mentioned about, I think it's a great point about the localization on the brainstem. I think with this right-sided facial droop and the left tongue deviation, I would think, okay, this is not a peripheral process, this is probably in the brainstem. But as you mentioned, we have two different localizations in the brainstem. I will look out for other cranial nerve involvement. And if not, could these be multiple foci that are affected? And for that case, atrial fibrillation is a great cause of embolic events. So maybe has this patient been going through a lot of strokes, and has this last stroke manifested as a transient loss of consciousness, rather than what we will, colloquially call a syncope. So yeah, I think this is a great case, Sandra. So thank you for bringing it, and I'm really excited to hear about the case. I would like to ask you both, what would you be looking for in the neurological exam, before I give you my thoughts on what I was looking for in my examination?
Wonderful. Yeah, I think I can start with what I will be looking for. So I think what we are trying to do here is to really try to have a grasp of what the actual localization because we're really having trouble because the main problem here is that the patient lost her consciousness, and now that she has cognitive problems and some apparently focal neurological deficits, but there is not just one process that can explain or at least not one typical process, not one typical illness script that can explain the whole picture. So what I think can help me the most is to look for signs of prior stroke, for example, for because that could make the stroke hypothesis stronger. For example, if the patient has a pronator drift or has some weakness on the extremities, that can point us towards prior stroke, I think. Apart from that, I'm interested in really identifying if this is a peripheral versus a central cause of facial facial involvement. Also, if the abducens is also involved, because if we are claiming a brainstem problem that is affecting the facial nerve, then we should also think about the abducens, because we know our anatomy. When the nuclei from the facial nerve generates the axon, it does it comes across the abducens nuclei, and then it also compromises it, and it causes diplopia, which we haven't seen so far. So that is something that I will look for also. And if the tongue is deviated, and then obviously I will evaluate the tongue, and I will really try to see if this is a problem with protruding the tongue first, because as I said, the test for to test for hypoglossal nerve function, it has to be a protrusion, and because that fires the genioglossus muscle. Also, other cranial nerves are also important. We are talking about 4, 5, 6, 7, 8, all till the 12th because we are covering the pons and also the medulla oblongata. And also, I would like to search for orthostatic hypotension because that can be assessed at the bedside, and yeah, basically measuring the blood pressure of the patient when she's in her bed and when when she stands up, and that is also important. And yeah, I think those are the main things that I will try to look for in this neurological examination. But I'm curious to know what is the answer from Arturo.
Yeah, as you said, I am really also interested about the other cranial nerves. Also defining very well if this is the central or a peripheral facial group. And also the cognitive examination, I think is really, really important, mainly relating the memory issues with the fact that the patient doesn't remember some of the events prior to the fall. With the cognitive examination, we can say if this is if the patient with memory issues is having maybe a retrograde amnesia or anterograde amnesia. Maybe that is what the patient is having, and maybe that is why the patient is referring those memory issues. Maybe that is why she doesn't remember the events prior to the fall. That's maybe if that is a problem of retrograde amnesia, that can be related to a diffuse process in the brain. For example, multiple strokes can present with retrograde amnesia. If there is an anterograde amnesia, maybe the problem is more focalized to some part of the temporal lobe, especially the hippocampus. Also, really knowing if this patient is having aphasia, examining very well the language part is really also important. Also, taking a MOCA test in this patient, taking a mini mental, willing do damage to the patient, because it is really important to know the state of his cognitive process in this patient. By 1 week of problem, I wouldn't really worry about some of the degenerative process, because all those are more chronic. But maybe this patient is having a very rapidly progressive problem, probably related to multiple strokes. So that is why I'm really thinking that the cognitive examination is also really going to be important.
So let's. Sorry. Sorry.
I wanted to.
Go ahead, please.
Sorry, I just wanted to make a point of what you mentioned because I think it's brilliant, and I also wanted to kind of put my coin down on what I think is going on. I think when we take pause and do a problem representation at this point, I think we can think, okay, this is an elderly woman with cardiovascular risk factors, AFib, that is presented with transient loss of consciousness and what seems like focalizing neurological symptoms. And when we frame it like that, I think, it is a very convincing case for stroke at this point for me. What are we looking for in the exam? And I think it's a great teaching point, actually, which I learned from a great neurologist called Dr. Marty Samuels in his neurological series that you can find in YouTube of his neurological exam. Is that the first part of the neurological exam also includes the cardiovascular system, because the brain is very dependent on the vessels and the heart. So we should start with auscultating the heart, examining the carotids, examining the vessels of the face and the neck, because you can hear a bruit, for example, in carotid stenosis. We can even, there's some I cannot do it right now because I am holding my phone, but you can check his YouTube videos. There are a lot of techniques that you can use that are not very, very good when it comes to the sensitivity and specificity, but they can give you an idea, and they can of how is the perfusion in the brain. And also, I would like to mention some tips on the examination of the facial nerve, because it's one of my, it's actually my favorite cranial nerve, because does a lot of things. Beyond the examination of the facial expression, which can be a little tricky, at least in my experience, because, often you ask the patient to smile and even you can, I often, when I say to the patient, can you smile for me? They often laugh because it's very awkward. But when you make a person laugh, that's another place of the brain that is working. It's not the facial nuclei. So, you can have a normal smile even when they have a problem in the nerve itself. So another tricks that you can use beyond that is also to examine, for example, the reflex of the corneal reflex with like I don't know what to call it, like maybe a piece of paper or something like that, to know if they have the reflex, because it is the efferent part of that reflex. You can also test, for example, for hyperacusia. If the patient is having, sensitivity to even normal sounds, that's another sign, because the facial nerve also innervates some of the muscles inside the ear. And you can also test, for example, for the taste sensitivity of the tongue, because it is the anterior part of the taste of the tongue. So, you can do all those type of things that, as neurologists, we'd love to get very esoteric. So yeah, I'm putting my coin down on a stroke, but would love to hear more of the case.
Thank you so much. That was that was really brilliant on the facial nerve examination. Yeah, and yeah, totally forgot those specifics about the facial nerve that come really into play when we are analyzing a case that is puzzling, that involves weakness on the face. So yeah, I think we can continue. Please, Sandra, go ahead.
Yes, so I will give you more information about the neurological examination. Well, the mental status is she's awake, she's alert, she's oriented to herself in the hospital and the month and the year, but doesn't know the date. And in a 3-word recall exam test, she remembers 2 out of 3. About the cranial nerve exam, the pupils are equal, round, reactive to light. There are no visual field deficits. There are no relative apparent pupillary defect. And also, the extraocular movements are intact. There is no gaze preference or deviation, no nystagmus. There is normal sensation in B1, 2, and 3. But there is mild right lower facial asymmetry. And there is not, the hearing is intact. About the palate, it elevates symmetrically. The uvula is midline. About the what more? It turns face to hand, shoulder, strong full strength in both sides, and the tongue is midline. The sensory function is also okay, intact to light touch and no extinction in 2 stimulations. The motor function is also well, not so normal, normal bulk and tone, no tremor, but in no pronator drift. But in the hand grip, the right side is 4 out of 5, but the left side is 5. Is normal. And the assessment in the extremities, in the upper extremities and the lower extremities, all is fine. 5 out of 5 or 5. The reflex, is also are also okay. Toes down. The extension is normal, no titubation, no truncal ataxia. The gait is also normal, and the coordination, yes, I think there is no any abnormality in this final part of the exam. So it was a big exam. I think a very complete exam. So I don't know if you want just this part of the information, or if you want me to tell about the labs.
Yeah, maybe you can tell us a little bit of, yeah, is it a lot? Yeah, I think it's okay if we get the labs. So
Okay.
to be mindful of everyone's time.
So yeah, just maybe you can discuss about it at the same time. So about the labs, we have this to save people's time. I kind of put the abnormalities in
Cursive.
in cursive, so you can analyze the more fast. The
Viren.
the urea is increased, the creatinine also is increased, the glucose is okay, the SAT is a little increase. Then the troponin and CK is also increased, and I think that's the main findings.
Okay, interesting. Yeah. So, Arturo, do you want to go first?
Yeah. So with a neurological examination, I think we can all agree that we have come to a conclusion. This patient is having a central problem. That was one of our main questions before. So I'm really glad that we have that clarified by now. Also, really having the clarification that this patient, in fact, is having some problems with memory. The fact that the patient doesn't orient to date, I don't know if that tells a lot about that, about the disease, but at least she can remember in which month we are. So I think that that's great. Also, really, I haven't really found any more in the neurological examination apart from what we have talked about before. In the labs, what I can think is a renal problem in the patient having that elevation of creatinine. By the age, probably we can really look about a lot of cases. Good can be a cause of renal insufficiency. But I am really also intrigued about the troponin I, because it's elevated, the Zika is elevated. So maybe we really should look again to the heart. What can be causing that problem in the heart? Well, we have a lot of factors. The hypertension, maybe also the hypertension was related to the renal issue. Maybe that was telling us that this patient was having a renal problem also. But again, all those can really come in an elderly woman as chronic issues. So hypertension can grow into an increase in the size of the ventricles, of the left ventricle, and that is a risk factor for making ischemic attacks in the heart. But we haven't had any chest pain. But it is also worth mentioning that elderly patients sometimes doesn't have chest pain with ischemic events in the heart. But again, I think, as Valeria said before, maybe this is really a case about multiple strokes happening in the brain. That is what I have to say for now.
Great thoughts. And yes, so this neurological examination, it appears to me that there are not many, the brainstem hypothesis loses its strength, because we aren't really finding any other signs of cranial nerve involvement apart from and we can now establish that this is a central facial nerve palsy. So that changes the picture, I think, because when we are saying that this is a central facial nerve palsy, then we are claiming that the insult has to be from the precentral gyrus, precentral cortex, which is the primary motor cortex, to all the way down to the choriona radiata, internal capsule, cerebral peduncles, and all the way down with through the midbrain and the pons till it reaches the facial nuclei. So the insult has to be on that part, and also the insult has to involve possibly the tongue we were discussing, but now the tongue is midline. So that's why this examination, I don't, maybe it is a typo, maybe it is that I'm not analyzing it in the right way, but now that the tongue is midline, it I don't know how to make sense of it. But if you guys know how to, please share your thoughts out loud. And well, apart from that, from the deficits that we have encountered, I think there wasn't a clarification on the speech on how or on if we are in a case of some type of aphasia, or if this is dysarthria. But so we can make progress on that, I think. And yeah, I would the next thing I would like to look for is an screening test for dementia, or just to see how is the mental status and the how is the patient in her cognitive faculties. And for the notable labs, yeah, what I make of the troponin and the CK are way too high for me to think that this is due to myocardial ischemia, because levels of that high, I think, suggest more muscle process, and it can also be immobilization, and it can also be drug induced. But the drug hypothesis, I don't think it's very strong, just because she isn't taking statins, she isn't taking fibrates, or any other of those myotoxic drugs. So yeah, I'm just very intrigued with these labs, with these particular labs. And also the troponin, for the troponin to be high, it has to be in the 5-day window, because it increases and then decreases in a very short period of time, compared to the CK, which decreases in a time frame of about 10 days. So troponin is more sensitive, but it appears that more sensitive and more specific, but I don't know how to make sense of it in the context of this patient that isn't really having not even chest pain, and she isn't even that old to begin with. She's only 62. So yeah, I'm just very intrigued, and I think the imaging is going to be really helpful for us to try to diagnose this patient. But yeah, I think we are going to be surprised with the final diagnosis, but I may be wrong, and this is just a generic case of a stroke, or just another case of a stroke. But I'm curious to know, what do you think, Valeria?
Oh, just another case of a stroke. I feel like there's no such a thing. A stroke is such fascinating. But yeah, I totally agree with your point. I think, this exam is reassuring, and I mean, I think it's a little frustrating as well on the lack of, focal symptoms. But I think it's reassuring in the fact that the patient is stable. Her blood pressure is fine, and as people that we are, I think our hypothesis right now is that she has a stroke or multiple strokes, but this acute stroke that has like 1 day apparently of history. We need to think about controlling blood pressure, which is fine in this patient. We often, when it comes to ischemic stroke, we have to think, okay, is this, alteplase, like, is this on the frame to, go to anteplase or not? And depending on that, we can think, okay, can we be tolerant with the hypertension or not? And for that, we have like the 180 over 100 of blood pressure, that threshold that we hold on to. But this patient is very normotensive, so we don't have to worry about that. I will be worried actually for her, because she is a hypertensive patient, and to be 120 over 80, it may be a little lower for her. So yeah, I would not rush to start her on antihypertensive medication just for the risk of the blood pressure growing even lower, and that kind of compromising the perfusion of her brain, which would not be great for her right now. And then to comment on the exam, okay, so yeah, we have apparent focal signs all over, the facial droop, the memory problems, which I think is the main thing. I agree we need to do like a further assessment, maybe a mock exam. And then on the labs, I totally agree. I think, the pattern of troponin elevation with CK elevation kind of has a more like muscle flavor to me. I think what Arturo mentioned about being worried about the heart is very, very important, because this patient has a lot of risk factors, and we would not want to miss that. So I think an EKG before the labs, I'm assuming, was done. So in that sense, I'm like, okay, maybe this is not the heart going on. And I think the possibility that this rise in troponin ICK is secondary to the fall and this is a case of maybe rhabdomyolysis, also causing the AKI that this patient is having, I think it's a great possibility. So yeah, I will entertain that, but of course doing maybe EKG and even trending the troponins, just to be sure, because as Arturo mentioned, these patients, when they are elderly, they can have a very, very silent clinical presentation, so we would not want to miss something like that. And then just to comment on some labs that are abnormal and we would want to correct them in a patient that has a stroke, and this patient, I mean, if this is not an acute case of stroke, she for sure has had maybe prior ones. It would be, for example, the hemoglobin A1C, which in patients with a stroke or TIA, we want them to have an A1C of less than 5.6. She's not far from that goal, so I think endocrine will be great, a great specialty to consult to. Another thing that we need to keep an eye on is the LDL, the cholesterol, and this patient has an elevated LDL. We often have a goal of less than 70 for patients that had strokes or TIAs. And then then other things that we look out for example, the TSH, just because the overall health of the patient really impacts, especially in the acute. And we often think about like the neurological factors of health, like pressure, temperature, like mental status, a lot of things. And this patient, we need to worry about that. So yeah, I'm craving some imaging, so I hope that's the next step. Oh, and I would like, what type of imaging would you ask for?
Wow. Thank you so much, Valeria. That was wonderful. And what type of imaging I would like? So since we have an stroke hypothesis, then a stroke code should be called. And the first imaging that a stroke code has is a CT without contrast, because we have to exclude first if this is an hemorrhagic stroke. And CT scan is very good for us. It's very useful for us to exclude any hemorrhages. So if the hemorrhage hypothesis, which is this case, is the most likely answer that this is not a hemorrhagic stroke, then we can move on to another test, which can be an angiography. The angiography can point us towards a foci of a thrombus or an emboli that it's obstructing a vessel. But we can also use a diffusion weighted imaging, the sequence, together with the ADC to look for true diffusion restriction. And just because in the after the 30 minutes, this imaging is very useful for us to detect an ischemic foci that can suggest a stroke, and that can be determined based on the diffusion restriction and also through the ADC sequence to confirm. So that is some imaging that I'd like to have. Also an echocardiogram and also an ultrasound of the carotids. It's essential for assessing this patient. So that is the imaging that comes to my mind first. I don't know if Arturo, you want to complement on that.
No, I think you talked on that very well. But maybe something more about the MRI, knowing that the patient doesn't really exactly know when did she fall and when did she wake up, when did maybe this last stroke episode was in the past day, and that reminds me of the role of the MRI in treating a patient that doesn't really know when his or her episode of a stroke was, because MRI, specifically in diffusion, and something about diffusion related to other contrast in the MRI. I don't exactly remember what contrast in the MRI, but that test really helps about knowing if this patient is candidate or no for an alteplase treatment. So that maybe knowing that the patient doesn't know when her probable stroke was, the MRI can be really helpful. But totally, I agree with you. The CT first, then the MRI, and then the other test to evaluate her general heart status.
Yeah, yeah. What you mentioned is very very important. And yes, I myself, I don't understand to the full extent how diffusion restriction or the diffusion weighted imaging works. I remember looking at a YouTube video trying to understand diffusion restriction, and the guy started talking about physics, and yeah, that's where he lost me. Yeah, I had to get to be humble and sit and try to learn a bit of physics to understand what diffusion is. But yeah, to be mindful of everyone's time, I think we can have the imaging. I don't know if Valeria, you wanted to make a comment before that, or we should proceed.
Just wanted to say that I think the teaching point here is that diffusion imaging usually shows a stroke after 1 hour of the incident. So it's like the fastest we can get positive imaging after a stroke. And then the MRI, we usually look at T2 and flare. And these sequences show up a stroke, I believe, at 4 or 6 hours. I don't recall exactly. So, if a stroke shows at diffusion imaging and not at T2 or flare at an MRI, we can think, oh, so this is lower than 4 hours. So this patient could be a candidate for alteplase. So that's very helpful in management. I think that's the teaching point here.
Yeah, something just to add a little bit more of information, that the time is very important in a stroke. So if when you are thinking about the management in a stroke, you can think about alteplase and ectoplase, which induce fibrinolysis, and also you can think about embolectomy, their direct embolectomy, where that is more of an invasive process. And yeah, that time window is very important, the 4 hours time window. So that's what Valeria was referring to, and I think that is a teaching point that should stay with us all. And yes, time is brain, Arturo, as you said. Yeah, so time is brain. Let's let's know the imaging.
Okay, so I have the imaging of the MRI, but I also have like the findings of the other imaging, but I'm going to show you the MRI images first, and then I can show you maybe the other information. So this first, I have I struggle finding the lesions and all that. I want to have all the information that maybe you can use for the discussion. So I have like like nine pictures, but I'm going to present it. And
Is
if
this
you want,
from the cases that you found on your rotation at Cornell?
yes, it's a real case.
Okay, so that's why this is a very puzzling case. Congratulations that you found this interesting case at your rotation. I just wanted for you to clarify something. Can you tell to us which sequences they are? Just for
Wait.
clarification.
No, we cannot cheat
Okay.
like this. If you're gonna
Yeah.
interpret MRI, we can do it right.
Yeah.
I mean,
Okay. Okay.
if you want me to go, I can go. Because this
Yeah.
is
Please.
really important, I think. So when we think about an MRI, we often think, okay, what is this view? We have first, in the right side, a coronal view and a longitudinal view in the left side, right? So like we have the brain like this and like this. And then we have the sequences. When we have T1 on MRI, it's usually the one that we look for anatomical structures. Is the most like anatomical one. And T1, I often think, okay, is how the anatomy is. So we think, okay, how are the fibers in the brain distributed? We often think gray matter. The gray matter is in the outer side of the brain, right in the cortex. So we will think, okay, the gray matter is in the cortex, and then the white matter is in the subdural, or like in the deep part of the brain. And I believe that's the right sequence that we're seeing here in the coronal view, because we have like a gray part before it becomes more white in the deep part. And then in the sequence in the left, we have the opposite. We have the gray part that is in the deeper side, and we have the white part that is kind of, like the outer part in the cortex. So, and then for the a sequence in the left, we can think, okay, so this sequence can be either T2 or it can be flare. And T2 has a very, very bright CSF. So T2, the CSF is going to be very bright, sorry. And flare kind of suppresses the CSF lightening. So in this case, we see that the ventricles are black. So the CSF is not very bright. So this is flare. If it was bright, it would be T2. So I believe, and Sandra, please correct me if I'm wrong, that the left one is flare and the right side is T1.
I think this is T1. This of the two sides are this and this at T1, and this is T2. But I also have flare. Maybe I can show you the other images. I have 3 slides. I think this is.
That is.
Yeah, this is T2.
T2, yeah.
Yes, this is T2, and the other, I think, yeah, T2. Both are T2. So we have T2 and T1, but I also have flare too. Yes, T2 flare.
Okay. Okay. Do you have more imaging?
No, that's all.
Okay. So, who wants to tackle this first? Yeah. I think. Yeah. I don't know if it is my turn. I've lost the count. I don't know if it's my turn or if it's anyone's turn. I think this could be actually a conversation, right? Because I think all of us had reflex thoughts. So why don't we share our reflex thoughts? So now I see a lesion that is very demarcated and that has a lot of peri-lesional edema. So I'm really worrying about a possible mass that is malignant. But yeah. No, not actually. Sorry. Let me rephrase it. I'm thinking about a possible neoplasm, but taking into consideration that this is not my area of expertise and the edema that we are seeing right now, it's way too extensive for me to think that it is just caused by that single lesion. I just think it is not the case. And this, and correct me please if I'm wrong. I think I'm right on this, but this is vasogenic edema, because of the pattern of involvement of the white matter, and we are seeing that it seems like it is starting to cross the corpus callosum, so that can be interpreted as the butterfly sign. And for butterfly sign, one of the causes can be glioblastoma multiforme, but this is not the typical mass of glioblastoma, which is not really demarcated like this one lesion. And also another hypothesis of a butterfly lesion, I think it's lymphoma, primary CNS lymphoma, but the lymphomas I've seen don't have this appearance of a well-demarcated lesion. But as I said, I'm not even sure if this is, if all this edema is just caused by this one demarcated lesion. It may be, but I'm not quite sure yet. And yeah, those are my thoughts on this image. I'm curious to know, what do you think, guys?
Yeah, it's very, very interesting. And so maybe to make the comment about before, we were thinking about a stroke because the patient had risk factors, the patient had a probably history and neurological examination compatible with multiple strokes. But then we see the images, and at least from the first two ones, the T1 and then the first flare that we saw, and also the T2, I wasn't really thinking really about a neoplasm. Maybe in that flare of the center, there was really about the displacement in the left ventricle that was occluding the anterior part of the left ventricle. So maybe that was really a sign telling us that probably may be a neoplasm. So I actually agree with you. This patient is having vasogenic edema with probably glioblastoma. In the last flare that we saw, the patient is having I think the ring type of enhancement in that center relation that we saw. That type of enhancement has a differential diagnosis that was, as I can remember, with the word magic Dr. L, and M was for metastasis, A for abscess, G for glioblastoma. I actually don't remember what I was for. And then I only remember the L of the last part, which was lymphoma. So maybe a glioblastoma. Sorry?
Toxoplasma, I think it's also ring enhancing, or am I mistaken? I don't. That may be wrong.
No, it's actually ring enhancement also, but also has other signs like the concentric hyperintensity or the eccentric hyperintensity, depending if it is in the cortex or if it is in the white part of the brain. So I actually agree with this may be a case of a glioblastoma or maybe a lymphoma with all that extensive vasogenic edema. So yeah, I think it's very, very intriguing knowing that this patient hasn't had a headache, hasn't had any really sign telling us that this may be a case of a tumor. But yeah, I find it really, really interesting. I don't know what Valeria thinks.
Yeah, I think well, your thoughts are I agree with some of what you mentioned. I think imaging is very, very challenging, but I think for me, I agree with the fact that these are very demarcated lesions. As you all mentioned, it seems like they are very located to one part of the cortex. Especially as we see like the first and the third image in this slide, we see that they go all the way from the outer cortex and to where the vessels will be starting, especially like the medial cerebral artery. And I think this type of very demarcated lesions make me think, is this a vascular territory? And that's kind of what makes me think, okay, I think it's a point towards a stroke. And another point towards a stroke is how a stroke progresses on MRI. And for that, and this is very, I think maybe a little advanced to know, because we think about the oxidization of the blood, or the ischemia. Sorry, how does it progress with time? And we think about T1 as the ischemic part is dead, so the ischemic part is black or darker. And we see this in the images that we see. The first one and the third one are T1 sequences, and we see that the side that is affected is darker. So it's like this part is affected by ischemia. And I believe the territories that will be affected maybe M2, M3 branches of the middle cerebral artery. And then we see the image in the middle, and we see that, there's edema for sure, and there's displacement of the midline, which can happen with ischemia, of course. We see that it's bright, and we think, oh, wow, is this like a ring enhancing lesion? And I think that's a great point, but I think what we are not seeing right now to point towards that is that these are not contrasted images, or at least not, they don't seem to me. So there are just images that are very hyper intense on flare on their own. And this slide shows that sequence, flare. And what can be hyper intense on flare? And a stroke is a possibility for sure. And as a stroke progresses with time, and with a peak of like 7 hours of after the incident has happened, it can be very bright actually. And then with time, it goes darker and darker and darker, because the blood or the site of ischemia oxidizes. The site of ischemia just kind of like goes more dead. I'm confusing myself between ischemic and hemorrhagic stroke. So yeah, and these sequences are also very demarcated in the sense that they compromise all the way to the outer part, to the part where the root or the beginning of the vessel will start. So I believe these demarcated lesions that are hyperintense on flare and hypointense on T1 are very compatible with the stroke of the M2, maybe M3 branches of the middle cerebral artery. And I think it's very interesting that this patient did not have any other like symptoms, like any weakness on the extremities, just like what seemed like cognitive and speech symptoms to begin with. So really thankful for your discussion and for you, Sandra, bringing this case.
Wow, that was amazing. Yeah, I think I've learned a lot in this case, and thank you so much for Valeria for jumping in, because your insight as a graduate doctor it's very helpful for us as students. So really, I'm really thankful for your presence today. And yes, now please do not reveal yet. Wait, just a second, because well, not actually. To be mindful of everyone's time, I think we can continue. Just yeah, please mention the imaging, and I think then
I might
yeah,
be wrong. I must say I might be wrong. So please don't give me flowers before Sandra mentions the final diagnosis,
no,
because I actually might be wrong.
no, it's okay. It's okay. I just wanted to mention that you really pointed out some brilliant thoughts, which is that common things being common. If we really have to stress the stroke hypothesis, and we also deviated from that hypothesis because we saw a mass, but a mass can coexist with a stroke, and that is something very likely. That mass actually reminded me of a cavernoma. I don't know why it reminded me of that, but the ring enhancement, I don't know if it is compatible with that. But if it is the case, there are cavernomas that are just not symptomatic, and that they just exist on the cortex because they form, and they are chronic in nature, so they just don't manifest. And this can be all caused by a stroke. That can be also possible, but the time frame, the time course is really puzzling in this case. I'm just very, very, very lost right now, and I think we all have to be humble right now and to accept any possibility that can come our way. So yeah, Sandra, please tell us more.
Okay, so maybe you already read or mentioned the findings in the MRI. So I also have the findings of the CT, but it's kind of the same: frontal temporal mass with vasogenic edema and midline shift. The MRI, as you mentioned, re-enhancing lesions in left frontal, temporal, and right parietal lesions, and with edema, and that will is causing sulfalcine herniation. But they also do a CT chest that shows right iliac and upper lung mass with associated lymphadenopathy and bilateral adrenal nodules. And that ACG is shows not like just bradycardia. I don't know if you want to talk more about this before
Yes,
I talk more.
yes. I think this puts the metastasis hypothesis into play, just because if we have CT chest that is saying that there is some lung mass, and there is iliac lymph nodes, and there is bilateral adrenal nodules, which is one of the main places where lung cancer metastasizes, then I think the hypothesis of this being a metastasis is very likely. But yes, I think no, I think I might be wrong, but I think this is a case of metastatic lung cancer. But I'm curious to know if this is just me anchoring or on something that I have on a flashcard, or if this that makes sense to you, this hypothesis, or this can be explained by another thing. This could also be, I mean, if I had to guess, when you find masses on the lung, and also you find mass on the brain, or a process in the brain, an inflammation in the brain, you can also think about, for example, infectious causes. But for infectious causes to cause this extensive edema, vasogenic edema, that I think that is very unlikely. What else? Yeah, apart from infectious causes, I don't think I can think of anything else. Sarcoidosis, maybe that, or nah, actually not. For it to cause that much damage, I think it's very unlikely for sarcoidosis to cause that. I think it causes orbital apex syndrome, but I don't know if it has a lot of neurological manifestations that can have, but I don't think this in particular is one of them. But yeah, this is me rambling on my reflex thoughts, and I don't know if you guys want to share any final comments based on the new information.
Yeah, for my part, I really love the explanation of Valeria, and also really knowing that when we saw the hyper intense ring enhancement lesion, we bumped into thinking that that image was with contrast. But as Valeria said, it is very important to know that ring enhancement lesions, we make differential diagnosis when there is a contrast in that image. And I think I agree with Valeria thinking that in that last flare, we really didn't saw the contrast, at least not the typical contrast that we can see in the vessels being hyper intense and really knowing, oh, that is a case of a flare with contrast. I think we really saw a flare with no contrast, but I may be wrong because that flare was different from the first flare that we saw. Maybe that flare really was with contrast and just we didn't see it in the vessels because that contrast was already washed out from the vessels that was just inside the lesion. I don't know, but I agree with Gerardo thinking with the findings in the chest, metastasis really comes to the first place. That is maybe really interesting because if we probably wouldn't see a ring enhancement lesion with contrast, I probably wouldn't really think about a metastasis. Probably because the patient doesn't have any pulmonary symptoms, doesn't have any problem related to a mass in the lungs, but that is also a typical case from patients with tumors, with cancer in their lungs, not having any symptoms until it's diagnosed by imaging, probably like this case. Also seeing the lymphadenopathy and with the possibility of sarcoidosis. Sarcoidosis, as Gerardo said, can cause a lot of things inside the CNS, inside the CMP. I don't know all the things that it can cause, but I think it was related to some type of mass, but I think it was an inflammatory type of mass. I don't really remember, but I agree with Gerardo. Sarcoidosis can't explain that level of pathogenic edema. So with all that, really, the possibility of the metastasis is really, really great. What are your Valeria?
I just want to say that you were totally right. This is a barely ringing enhancing lesion, so kudos to you. I'm really shocked. I was stunned by the images. I would like to review them more because I feel like I totally missed that part of the reading. But you totally caught it. So as I said, good for you. And I just wanted maybe to contribute to, yeah, I agree that it seems like there's a metastatic component to this. I think um, when we think about brain metastases, we often think about 5 main sources. First being melanoma, so a skin exam is very important. Then being lung and breast, which are the most common tumors overall in male and females, respectively. And then we think about thyroid and also kidneys. So, that's kind of the whole assessment we need to do. Like maybe a full CT of thorax, pelvis, and abdomen. Then the skin exam, the throughout skin exam, because melanoma can be very aggressive. And then maybe a UA, this patient had an AKI to know if this is their baseline or if this may be something abnormal, maybe something that we need to look out for. But with this imaging of the lungs, it really is, it's easy to anchor on, okay, this is lung cancer that is metastasizing. But yeah, I mean, I guess the main teaching point of this is that I should not anchor because I anchored in a stroke and I was wrong. So yeah, great discussing this with you guys.
Thank you so much. Yeah, Sandra, please tell us the diagnosis. That was amazing discussion, guys. Amazing.
Yes, it was really interesting. Well, after this finding, I think the neurosurgery team start to act because they perform a craniotomy with the resection of the principal tumor. I think that was on the frontal part of the brain, and with this. Um, with this tumor, they biopsy the tumor to see which is the origin, and the results were a poorly differentiated metastatic carcinoma, most consistent with lung adenocarcinoma primary. That was the result. PDL1 positive and EGFR positive. So yes, that's the final diagnosis of this patient. She has we she was found with this brain metastasis of lung primary adenocarcinoma, and with this genetic testing of the FGFR, we can also with the PDL1, we can give her this target therapy. And also, it's quite good. She's in a good performance or physical is she's functional, so she has these target mutations that will be helpful, and I think this
There are drugs
hospitalized.
there are drugs for them. There are drugs for these specific mutations.
Yes,
Yeah.
exactly.
Wow.
Yes.
Do you have anything more to add, Sandra?
No, just maybe seeing the notes from the emergency department. It was I changed the point of view of this case because when I see the patient, I already know it was lung cancer and already know that it was metastasis. We were talking more about the therapies and stuff, but then I see how the patient present to the emergency department, and I see that the diagnose was quite difficult, especially for the neurology team, because they consider a lot of hypotheses like you, tumor, metastases, infections, metabolic, but until the imaging, I think they didn't find the answer. So I think you did it really great. It was a great discussion. I am glad that this case was not that easy. So, yes, that's all.
Yeah, who would have thought that a patient that presents with transient loss of consciousness or syncope would end up having metastatic lung cancer? I wasn't expecting that. That was wonder. Oh, and the hypothesis of maybe what if the metastasis to the adrenals caused there is not enough catecholamines, and there is not enough catecholamines, there is not an adequate control of the blood pressure, and that causes hypotension, and that can cause loss of consciousness due to hypotension because there's hypoperfusion. That is a hypothesis that we could have. No, but it is actually too. That is for the internet. No, but I think no, that was just a joke. Obviously, we do have to.
I say it's true because I saw a patient with adrenal carcinoma that presents with multiple folds due to orthostatic hypotension. So what you mentioned is right.
Okay, yes, thank you for saying that. And yes, what an intriguing case. I think this is the best case so far we had because this took us a lot of places. We even discussed brainstem anatomy. So I'm really happy that this academic project that is conducted by just med students here is really doing so great because of the people that is involved here. I'm really happy that Valeria accepted and is here with us and shared her brilliant thoughts. I really appreciate you so much, friend. And yes, we are very happy for the results today, and we look forward to seeing you all in the next session, and maybe share your thoughts out loud this time through the chat. And yeah, I don't know if any of you guys have any final comments. If not, we can close the session.
I also want to say thanks to Valeria. That was really an amazing discussion. We really learned a lot today. And I was really also intrigued by the final description of 2 left frontal and 1 right parietal lesions. I think we all missed that in the images. But I don't know if Sandra, in the images that we saw, were there those masses, or because we really talked about those. But I think if we will really saw those masses, we will really have the whole picture of a metastatic brain lesion, because metastases are usually multiple in diverse places inside the brain. So with that, metastasis will probably come first when we just saw the first image of the flare. So yeah, I agree with this. Was a really amazing discussion. Thank you, Sandra. Thank you, Gerardo, and thank you, Valeria.
Thank you all. And I forgot to mention that Guillermo was doing the teaching points. So I don't know if Guillermo wants to make a small comment on what he has learned as a second-year med student. I don't know. Just a small brief comment?
Yes, well, I think I can say that I agree with you. You mentioned that I think that is a pretty interesting case. I think I've learned a lot. So yes, thanks.
Thank you so much, Guillermo, for your teaching points. We'll read them in very detail after this session. And yes, thank you so much, everyone, for being here. And let's see each other in the next session. Goodbye.